local anesthesia as a term, it's either local anesthetics or regional anesthesia. From the name, نسمع لو سمحتوا. From the name, regional anesthesia, it provides anesthesia for a certain or region part of the body by the use of local anesthetics. Local anesthetics itself are drugs that blocks the propagation of the impulses for excitable tissue, whether it's nerves, skeletal muscle, cardiac muscle, brain. It depends exactly where you inject your local. And then it stops the propagation of the action of the impulses afterwards. Mainly, we use it peripherally. How does it work? Anyone knows anything about local anesthetics?
Sodium channel.
Sodium channels.
Sodium channels. But for it to get to the sodium channels, it needs to pass through the cytoplasm of the cell membrane. So it needs to get to the cytosolic side. Initially, it needs to be charge-free, lipid-soluble, pass through the membrane, then get charged inside the cell, and then it activates or blocks the sodium channels. Inhibits. Now, it reversibly binds to the voltage-gated sodium channels. This inhibition prevents further influx of sodium channels, preventing further action potential. Penetration and dissociation. As I mentioned, initially, once you give it, it will be in equilibrium between the ionized and the non-ionized forms. We need the non-ionized forms to cross the cell membrane to get into the cell, to the cytosolic side of the membrane, and then it needs to be re-ionized, and then for it to be to act on the sodium channels. Local anesthetics are either amides or esters. Each local is composed of an aromatic group and an amino hydrophilic group. The connection in between defines whether it's an amide or an ester, and it gives the local anesthetics its characteristics. So, the esters, it's simply an ester group, and amides, an amide group. What do we have as an amides? Lidocaine, mepivacaine, bupivacaine, etidocaine, and prolicaine. Mostly we use lidocaine, bupivacaine, and prilocaine from them. And there's other variants as well. As a hint, anything with two eyes is considered an amide group. Ester groups, cocaine, procaine, chloroprocaine, and tetracaine, all of them are still used in medicine nowadays. Ester groups are less stable than amide groups. Amide groups is less stable and more longer acting. Once absorbed, they can penetrate the blood-brain barrier. Esters have low volume of distribution due to their metabolism by the pseudocholine esterase. It's the same one that metabolizes mevacorium and succinylcholine. Amides have high volume of distribution. The ester group metabolized by plasma and hepatic esterases, and the amides in the liver by the P450 system. Excretion via kidneys. Onset of action depends on the pKa, as the pKa will determine how much non-ionized is there. So, the higher the concentration of the base, the non-ionized form, the faster the onset. The lower the pKa, the higher the non-ionized form. Duration depends on the protein binding. More protein binding, longer duration, and more toxicity. Potency depends on the solubility. Agents highly soluble penetrates the nerve membrane more easily. Unique needs, it depends on the type of procedure, the duration that you need the limb or this block to work, and if you need to preserve some motor action or not. So it depends on what you need, what type of procedure you're doing, and potential for toxicity. Bupivacaine is the most toxic one. Local anesthetics agents. These are the most common, but there's still more. Bupivacaine, lidocaine, and chloroprocaine. maximum doses and maximum doses with epinephrine. Usually when we inject a local anesthetic in a certain tissue, we have two options, either to inject it as a sole agent or with epinephrine. Why epinephrine? Because there you go. Press. Thank you. With epinephrine causes a vasoconstriction, which will limit the absorption of these local anesthetics, which will give you a little bit more time, a longer duration of action, and a higher safety margin. Chloroprocaine is one of the short-acting ones. There is a heavy form from it that we use in spinals. Lidocaine, not used in spinals, used peripherally, but it's still one of the shorter durations. Bupivacaine and ropivacaine both have longer durations. Ropivacaine have a little bit of motor sparing, not completely, but there is a little bit of it, motor sparing. So the motor function comes back to your patient before the sensory ones. Vasoconstrictor is epinephrine. You cannot inject it at any point of end arteries, so fingers, toes, nails, earlobes, and penis. If there is an infection, the local anesthetic won't work. Why? The tissue will be acidotic. So most of the local anesthetic will be in the ionized form, so it won't be able to cross any of the cell membranes, so it won't work. Or it is delayed. Systemic toxicity occurs by accidental intravascular injection or overdose or unexpectedly rapid absorption. There is some areas that we inject in it that's highly vascular, so if you inject without keeping in mind your dose and the vascularity, then you might end up with a systemic toxicity. Or accidental intravascular injection. What happens if there is a local anesthetic toxicity? Your patients presents, usually the first thing they will be having a tinnitus in their ears and a numbness in the tongues or around their mouth. This is the first thing that happens. This is usually a simple one. But then there's disorientation, drowsiness, visual disturbances, muscle twitching, might be up to consciousness, seizures, hypotension, arrhythmias, and generalized CNS depression, coma, and respiratory arrests. You have to recognize it early. The trick about solving this or treating local anesthetic toxicity is to keep it in mind in patients who are already on local anesthetics. Especially, most commonly, patients in labor ward with epidurals. Because epidurals are given through catheters. And if this catheter migrates into a vessel, then you're injecting directly into the bloodstream, which increases the risk of toxicity. So you have to keep it in mind once you're giving patient any kind of infusion of locals. Treatment, early recognition. Early recognition, call for help, ABCs, as any other emergencies. And then it depends on your symptoms. So seizures or sodium thiopental, if there's seizures, diazepam or sodium thiopental, if there's seizures, there's arrhythmias, managed as well. And then it sometimes can get into the arrhythmias into a cardiac arrest. You have to expect that or work against it at least. You have to manage by intralipid 20%. Every place in the in theaters, around theaters or around labor ward that you're giving local anesthetic infusions, it should have an intralipid in place. And if you're giving it, you need to know where that is, because it can be life-saving. It binds to local anesthetic in circulation, so it decreases its concentration within the tissues, so it might start to detach. That's how it works. We've already talked about this. Okay, kind of blocks. Talking generally, it depends on what kind of procedure you're doing. So, if you're doing an upper limb procedures, you can just do either an interscalene block or a supraclavicular or infraclavicular blocks. Each one of these would numb or put local anesthetic around the brachial plexus, making the hand completely numb for that procedure. It depends on what level of procedure you're doing, what level of surgery you're doing. Is it only the hand list or an elbow or a shoulder? The shoulder, the interscalene is not enough. You need a little bit of local infiltration next to it. Otherwise, it won't cover it completely. But I've done lists with only hand trauma lists, only with a regional anesthesia, doing either supraclavicular or interscalene. It's really handy because your patient is awake, pain-free. They will still pain-free intraoperatively and postoperatively. They can go home the same day without any of the complications of the general anesthetic. Lower limb as well. The whole lower limb is, you need to cover 3 nerves, so femoral, obturator, and sciatic. If you cover all 3, you can do any of the procedures without any general anesthetic. So foot, you need femoral and sciatic. Up to the knee, the same. Obturator is a little bit higher. Then we have the neuroaxial blocks. Neuroaxial blocks is a spinal and an epidural. We'll talk about it a little bit later. This is a fracture hematoma block. Basically, you have a fracture around the wrist or in the hand. There's a hematoma around it, and you inject within the hematoma. It's very rarely used. I've never seen it. It used to be, we use it the old days, but not anymore. There's a higher risk for toxicity because you're already injecting in the bloodstream. And there's a high risk of infection because this is a closed fracture, and once you inject into it directly, you just made it open to the system. Topical anesthesia. This is mostly used, especially with kids or anyone who's needle phobic. We have a mixture of prelocaine and lidocaine, 2.5% each. It needs at least 30 minutes to work, and we use it for intravenous access. It makes it a little bit more numb. The only problem is if you only have one vein and you fail to put a cannula in it, and then you're gone. You need to wait for another half an hour, an hour. Pierce block. Pierce block is also an intravenous one. It's contraindicated for all the agents except lidocaine, so it's usually managed with lidocaine. We have 2 cuffs, 2 tourniquet cuffs up in the arm with an IV access at the tip of the hand, usually for any surgeries within the hands and the forearm. You inject the local anesthetic, which is lidocaine. It will, with the cuff up, more than blood pressure. So the whole arm below the cuff will be numb at that point. Once that's done, you can do your surgery. More effective, safe, pain-free. The only bit that's annoying that most patients does not tolerate the pressure of the cuff itself. That's why there is 2 cuffs. So initially, we inflate the more proximal one. Once we make sure it's all anesthetized, we deflate the upper one and we inflate the lower one, which is supposed to be a little bit anesthetized below it. You cannot deflate your cuff with less than 45 minutes because that's the duration for action of lidocaine. Otherwise, you'll have a huge amount of lidocaine into your bloodstream, into your heart, increasing the risk of toxicity. Absolute contraindications, as any other procedure: patient refusal, hypersensitivity, impaired perfusion to that limb, DVTs or thrombophlebitis, uncontrolled hypertension, relative ones, uncooperative patients, obesity that might make the cuffs unreliable, neuropathies, arrhythmias, surgical procedures lasting over 1 hour, because the lidocaine will only last about 45 minutes, give or take. The second part is our spinals and epidurals. Okay, we still use local anesthetic, but it's called neuroaxial because we inject it around the spine or the central nervous system. Patients remains conscious, usually used for anything below the umbilicus. If it's the low kind of anesthetic, spinal is a single shot thing. You go with the 1 needle through the layers, from the skin, from the back. We'll talk about the layers in a bit. Once you reach the CSF, you inject the local anesthetic. It will numb your patient, usually from T4 down, but it's reliable mostly for anything below the umbilicus. And it provides very good, very sensitive, very dense anesthesia, which is very good for most procedures. The only problem that it's single shot. It would last around 2 to 3 hours. Afterwards, it's not that reliable. So if you have a procedure that's longer than that, you can give it as a second anesthetic or an analgesic option, but not the sole anesthetic. As for epidurals, we go proximally to the same area. We go to the epidural space where we have all the nerve endings coming out from the spinal cord. Once we get there, we insert a catheter, a very small catheter into that zone, which provide analgesia or anesthesia if needed for anything from umbilicus down. So we can do cesarean sections on those on labor ward who have epidurals. It's not as dense as the spinal anesthetic, but it's very good. And it can be topped up as long as you need it. So once you are happy that the block is working with an epidural, it can last for as long as we need it. It can stay for at least 2 to 3 days. And then we start negotiating if there's increased risk of infection or not, depending on the situation, where the patient is, and how's the care. And there is the peripheral nerve blocks that I've already talked about, either an upper limb, lower limb, or specific points. Relative indications, patient's preference. Patients want to stay awake, or patients want to see. We do that here in Jordan. In many private hospitals, there's screens for the patients doing lower limb surgeries. So they prefer to stay awake. It's much better for post-op analgesia because they stay pain-free for a few hours. Decrease the incidence of nausea and vomiting. They'll be awake, so there's no sedation. They won't be foggy or need a few hours after the general anesthetic to be fully awake. Shorter recovery, improved rehabilitation, less risk of postoperative nausea and vomiting. GA is not available is an indication. Patients with high-risk cardiac or respiratory system diseases, we prefer to do regional if it's an option. If it will cover the surgery properly, then it's a very good option. Patient's preparation, sedation, not all patients require sedation. Sometimes they are just anxious about what we're doing. Once it's done, they're anxious about the needling more than anything. Once it's done and they're happy that their arm or leg or whatever is numb, they're okay. Monitors, as any other anesthetic, it needs the least, all the monitors that's required in any anesthetic, which is, any idea about the monitors that we use? Each anesthetic requires an ECG, a pulse oximetry, a blood pressure, sometimes capnograph if we're doing a general anesthetic. If we're doing a spinal, you don't need to monitor their breathing because they are awake and talking to you. But if you give them sedation, we usually ask for a capnograph, which will detect the CO2 coming in and out. Patient should be prepared for GA. Yes. Now, ideally, all patients should be prepared for GA because any complication can happen intraoperatively. So once you consent your patient for regional anesthesia, you have to consent them as well for general anesthetic. They should be ready, they should be fasting. If there is a risk, they should know about it. If we need it, that's fine. If we don't need it, then it's gone. Sometimes regional anesthesia doesn't work as well as we want it to. Ideally, we should test it beforehand, before the surgery starts. If it's not working, then we convert before they start. But sometimes in the middle of surgery, like the duration of the spinal ends within 1 hour instead of 2 hours. With regional anesthesia, if you're anesthetizing a limb, you might miss a nerve ending. So there will be a certain point causing pain at that point. So accidents happen. It's not always perfect. Benefits: reduced pulmonary complications, reduced analgesia requirements, postoperative nausea, vomiting, reduced blood loss, ability to monitor the CNS during the procedure, improved perfusion, and less risk of DVTs. Complications: failure of the technique, total spinal, we'll talk about that in a minute. Systemic drug toxicity due to overdose, injury to root ends, nerve ends, spinal cord, and epidural hematomas and infection. Total spinal is injecting too much of the medication within the CSF, which makes the drug go higher and higher within the spinal cord, which might cause bradycardia or cardiac arrest, basically. Because the cardiac accelerators are at what levels? Spinal?
Midbrain.
Midbrain, respiratory center. Cardiac accelerators is more like T2. Okay. Injury to nerve roots and spinal cord. We're going blindly with a needle around the spinal cord. Now, the level at which we go in will determine if you're safe or not, because you're going directly into the CSF. If you go higher, then you'll go into the spinal cord, and this will cause injury. If your patient has an infection in the area, in the back, and you go with an injection in there, you will introduce an infection to the CNS system, causing meningitis, encephalitis, or other complications. If your patient has a bleeding tendency or they are on anticoagulants and you go with an injection into that place, then you will cause a hematoma. A hematoma will cause a compression either on the spinal cord or in the area, which might make your patient paralyzed if you don't go with surgery within the next 6 hours. Where to go? Spinal cord ends at level of L2 in the adults, and the dural sac ends at the level of S2. Nerve roots, coda equina from L2 to S2. A needle inserted usually below L3. So if you look here, I think I have a picture. Yes. This is the most common position that we position our patients in. We palpate in the back. These are the spinous processes, these ones in the middle. These are the one you feel. It's called the spinous processes. It's safe to inject at any level below L2, L3. How do we know? The iliac crest. The iliac crest usually is between the level of L4, L5, and then you can count up from there. Okay. These are other positions. Usually, we've never used this one, the jackknife position, unless it's a caudal, which is a type of epidurals that we use for adults, which is very tricky. Usually we use caudals with pediatric patients, so we never use this one. Usually it's either this or that position, lateral position. This is the most convenient one because the patient stays in the midline, and you can feel the midline, which makes it a little bit easier for you. But some patients feel dizzy, in pain, cannot sit like this, so this position can also be lateral decapitated position. Structures that we go through. Okay, we have skin, subcutaneous fat, then ligaments. We have the supraspinous. Now the things that you feel are these ones. These are the spinous processes. So these are the tips that you feel from the outside. We have the supraspinous ligaments, which is over on top of all of them. And then we have the intraspinous ligaments. And then we have the ligamentum flavum. Usually once the anesthetists pass the ligamentum flavum, they can feel a click, they can feel a pop, and then you know where you are. This is the dura and arachnoid attached to each other. So this space would be an epidural space. This is where we put our epidural catheters, in this space. It has nerve index, veins, arteries, lymphatics, and a little bit of tissues. Then, as I said, dura and arachnoid. Below that is subarachnoid. Subarachnoid means you're gonna get into some CSF. If you go higher, you get into the spinal cord. Lower, you have coda equina. So even if you go low, there's still a chance that you might hit a nerve ending, which means that you might have a complication. You need to be careful about that. That is a risk that we sign each patient for regional anesthesia for. There's a risk of nerve injury. We've already talked about the deposition site. Onset, spinal is much quicker, much rapid onset. Usually within 2 to 5 minutes, you will have a perfect block. Onset of the epidural, it needs higher volumes and a little bit longer time. Usually with an epidural, there is a walking epidural that we give lower concentrations of higher volumes of local anesthetic, which will preserve their motor function and takes their sensation. Effectiveness of the block, it can be variable. This is very effective. Why this is variable? Because you never know what's happening inside. Sometimes, and this is also what we consent our patients for, sometimes it can be unilateral, sometimes it can miss a spot, sometimes it can miss a nerve. And there is a few tips and tricks that we can do to improve the block, but sometimes you just need to take it out. How do we know that this is an epidural space? Simply, as we're going through the ligaments, there is a continuous resistance. Once you lose that resistance, you know that it's an epidural space. But this can happen with different options. So you never know until it works. As well, when you insert your catheter, you never know where the catheter goes in, because if you find your space at around 8 centimeters in the body, you leave around 6 centimeters inside. You don't know where these 6 centimeters went in, if they went into the CSF, if they went into a vessel, if they went into outside the epidural space. Difficulty, technically more difficult. As I said, you never know where you are because you're working blindly. Patient positioning. This means not during insertion. This means after. This is talking about after we put it in. Usually with local anesthetic, we use hyperbaric solutions. Hyperbaric solutions means it's much denser than our CSF. Means that if the patient is sitting, it all would sink down. If the patient is flying down, it will sync with the curves of the spinal cord up to T with the curvature. Specific gravity spread, as I said, this is the same thing. With epidurals, it's not hyperbaric, so the positioning is not important. Instead, the volume is important. You need much higher volumes with epidurals. Continuous infusion only with epidurals. Complications, epidural. Failure of the technique, hypotension, bradycardia. Bradycardia only if there is some cardiac sympathetic accelerators block, which is T4 to T2 to T4. Epidural or subarachnoid hematoma. If you hit a vessel or if there is a bleeding tendency for your patient. Accidental subarachnoid injection can produce spinal anesthesia with a high spinal. If you hit or if your catheter migrates into the CSF, which is subarachnoid, from the epidural to the subarachnoid level, and you give the same dose that you're giving into the epidural into the spinal, you will have a very high volume of local anesthetic. And this will cause a high spinal, and then at that point, you are already blocked your cardiac accelerators, and you might reach your midbrain, so you might have a very bradycardia or cardiac arrest with respiratory arrest. At that point, you need to support your patient. Systematic toxicity of local anesthetic. If your catheter migrates intravenously, catheter complications, the catheter might kink or shear, or you might lose it within the body of your patient. Infection or duropuncture. Duropuncture, we'll talk about that in a minute. Spinal, failure of the technique, hypotension, bradycardia. خلصنا. حملوني معلش. شكرا. Epidural or subarachnoid hematoma, post-spinal headache, transient paresthesia, spinal cord trauma or infection. Post-spinal headache or dural puncture will present with the same symptoms. It's basically when you hit the arachnoid layer And then there's a CSF leak. It happens more, or we see it more oftenly, with the epidural catheters because it's much larger than the spinal ones, which means that there is more and more CSF leak. Once that happens, there is more tension because the meninges is already connected around the spinal cord and around the brain. So there is more tension around the brain, causing the headache, which we call it post-dural puncture headache. Usually within 6 hours up to 3 days after the dural puncture, because of CSF leak, and it's because of the tension of the meninges on the brain. It's usually positional because once you sit, there's more tension. If they lie down, it's fully relieved. Usually it's occipital or frontal tension headache, and might present with other motor deficits, and this can be a bit worrying, which is tinnitus and diplopia. Usually we try to manage it conservatively. Fluids, rest, and caffeine, because caffeine would stimulate the synthesis of CSF. Simple analgesia, we start with paracetamol. If that all doesn't work, if the patient is still incapable of taking care of herself or her baby, especially after deliveries, because that's the most common place that we put epidurals in, we try to do an epidural blood patch. It's a fully sterile procedure. It's rarely needed, but if it happens, it should be done by the most senior anesthetist on the organization, because there's still another risk of another dural tap. We go into the same place, or a level higher or level down of the epidural. We go with another epidural needle. We take some blood from the patient and we inject it in their back. This way, it should clot on the leak site, and that should be it. Most of the patients, 50%, they will have pain-free or will be headache-free within a minute. While you're still injecting, at that point you stop. Some patients, it won't work. And that's it. All done. No, still there. We have absolute contraindications. Lack of trained personnel, lack of resuscitative drugs, patient refusal, allergy, infection, coagulopathies. We've talked about almost every bit of these. The only one that we didn't talk about is raised ICP. If you're doing a spinal, أنا آسف حكيت خلصت ورجعنا كملنا معلش ضلت سلايد. استريح. Raised ICP. If you're doing a spinal anesthetic and you go into the CSF and there's high ICP, there's a risk of herniation of the brain. So anyone with brain masses, it's contraindicated to do a spinal. Severe hypovolemia, sepsis, and bacteremia, because all of the regional anesthesia cause a drop in the blood pressure due to the sympathectomy that happens below the level of the block. So if your patient is sepsis and bacteremic, first, they will be hypotensive. Second, there is a risk of introducing disinfection into the CNS system. Lack of IV access is an absolute contraindication because their blood pressure will drop and you need to manage that very quickly. If you don't have an IV access, that's a no-no. That's a major mistake. These are relative contraindications. For long surgery, we talked about the duration of the spinal, pre-existing neurological disease, because you never know if the injury is from the spinal or from the original disease. So most anesthetists prefer to skip anyone who has a neurological disease. Thank you.